Well, good morning from Kansas. It is still morning here. I believe it is not morning there anymore, but I am excited to get to share some research that I have pretty much spent my entire academic career formulating and conducting. So, as the introductor mentioned, I am a professor at Wichita State University. I've been Dr. Kim since 2004. Before that, I was a licensed teacher. I taught kindergarten, and my master's is in speech language pathology with an emphasis in language and literacy. And since I've been Dr. Kim, I have spent hours in classrooms working with kids, with teachers, and with families, and really trying to navigate what are the factors that really predict and impact youth outcomes. Because it's not just teacher knowledge and it's not just the curriculum that's being used, it's a host of factors. And then finding ways to support those through community engagement, through parent training, and then through direct intervention and teacher training. So this presentation kind of synthesizes 2.5 decades worth of work. So we'll start with a little bit about the background. So as I mentioned, child outcomes are shaped by social factors, emotional well-being, the educational context that they're served in, and then environmental influences. We know that there are fragmented systems that exist, whether it's a fragmented social child welfare system, it's a fragmented mental health system, it's a fragmented educational system. We know that those fragmented systems delay our ability to provide prevention or targeted intervention for youth who might be expressing some risk factors. We know that a lot of children in our schools today have experienced significant adverse childhood experiences, or ACEs, which is a way to kind of capture trauma or traumatic experiences that they've experienced in their life. We also know that social determinants strongly predict the trajectory of child's development and, if you will, success. That trajectory is greatly determined by social determinants such as mental health, such as parental educational status, such as social emotional skills. And then some recent research that I've been engaged in really has looked at a child's ability to regulate their emotions, so emotional regulation. And that research has really strongly indicated that that is directly tied to academic success as well. So the problem that this line of research addresses is we know that children face psychosocial stressors. Childhood is not innocent anymore. And services are siloed. So you have the services in the schools, you have community services that may or may not be offered during the school day. You have segmented social welfare systems that don't connect with each other, that don't communicate with each other, and that don't share data. So lots of children are kind of lost in the system. And there is no true way to really know what all the child's needs are, what the strengths are, and then services that can be provided to support that child. That then leads to delayed intervention, right? As the teacher, I'm seeing certain things that the child may be experiencing, and I'm having interactions with that family. And so I may make a referral, but then depending on the agency that the child gets referred to or the family gets referred to, it may be a 6-month wait. It may be an 18-month wait. It just kind of depends on the agency or how quickly the family takes advantage of the referral. And in my community and in the United States, there is an over-reliance on clinical-based models. So fragmented care systems, and we know that those reduce access and continuity. And we know that there's a distinct disconnect between school and what's happening at school and what might be happening in a clinic or in an outreach setting or in an after-school type of resource that's maybe engaging with the child. And I really focus a lot of the work that I do on schools because that's a natural context for children. They're in school more than they're at home during the week, during awake hours, right? So school is a very natural context to not only learn about the children, develop trust-based relationships with the children, but also really target some of these psychosocial stressors to help bolster their protective factors and mitigate risk factors. And then oftentimes we have children that are having crises and risk factors that we know nothing about, even though we see the child every day. So why this focus on social pediatrics? Well, social pediatrics is really kind of a melding of multiple systems. So we have the clinical or more the medical side, we have the child welfare side, we have faith-based side, we have the educational system. And so social pediatrics is a way to really integrate care and support for children and families across systems. So it focuses on the whole child, not just that the child is failing math, or not just that the child needs food. It's the whole child. What are the entire child's needs and strengths? So it's a strengths-based approach. It does address social determinants of health, and it builds this notion of prevention or early intervention into daily environments. And remember, I just said the daily environment for a child is typically a school, right? School is a safe place, typically. School is where a child has perhaps the only meals they get a day, and a loving adult that can pour into that child. That happens in school. For most children, that is a good natural environment in which to deliver prevention services. So again, social pediatrics really integrates health, education, and community, and it focuses on upstream prevention rather than reactive care. So rather than waiting until the child gets suspended or expelled, or waiting until the child is touched by the juvenile justice system, we're going to focus on prevention because there are risk factors associated with those less than optimal youth outcomes. And so by identifying those and providing services for the child and the family, we're going to focus on prevention rather than reaction. So the objective of this really is to of this presentation is really to look at what does this community-centered prevention and early intervention model look like, and how is it grounded in social pediatrics? So the model overview is it is a school-based support model. So again, most of the services that I'm going to discuss are delivered in school because the child's at school for an extended period of time. And it also removes the barrier of the parent having to figure out transportation or taking off work to then take the child to a clinical setting or to an off-site community center. We're going to provide the supports right at school where the child's at during the school day. Now, that doesn't mean we're not going to also recommend after-school supports and things as well, but at least the primary dosage of support will happen during the school day. There's also a focus on family engagement. So families are invited. We also realize families work, and so that's why we offer additional supports to the family outside of the school day. We focus on community partnerships because I am a firm believer that teachers cannot do it alone. Teachers have enough on their plate in terms of delivering the content that they cannot reasonably be expected to provide all of the levels of support, nor can families, right? Families can't do it all themselves. And so it really is a community pushing into the school during the school day to wrap around services for the child and then layer those in the after school space for families. And most importantly, it is a relationship-centered approach. So my research and the kind of the theoretical framework really believes that you can impact no change in a child's life without connection and relationship. And so it's built on this notion that you have to build a trust-based relationship with this child in order to have any sort of impact in the child's life. So the core components of this model are daily relational support. So I'm going to discuss here in a bit a research project that we did with one of these community agencies that pushes into schools and provides daily relational support to the child through a targeted, culturally congruent mentoring model. So children are identified by either the school staff, the school social worker, maybe an outside entity does a referral, or maybe the parents, self-refer. And then the mentor is at that school every single day. This is not a school staff member. This is a community member who's coming to the school every single day. And the entire purpose of that check-in is daily relational support. They're brief, they're not therapy sessions because, again, the child's at school and we need them to learn reading and writing and math and all the things. But it's a daily touch point so that the student knows every single day Mr. Dex is going to come to the school and he's going to check on me. And if I have something I want to celebrate with him, I'm going to get to do that. If I have something heavy that I need to share with him, I'm going to have an opportunity to do that. It's really that the child learns outside of the family and outside of the teacher that there is another caring adult present every day that has a relationship with that child. And that's the entire center of the entire model, is that relationship. They also target social emotional learning and executive function. There's a lot of research out there that says executive function is a necessary prerequisite to any learning that's going to occur, right? So I often use this visual model. So if you imagine this is the brain and this is the prefrontal cortex, right? That's the part, the thinking and the reasoning part of the brain. And inside here is the amygdala, and that's the fight, flight, or freeze response. So oftentimes children come to school with their lid flipped, meaning they're already dysregulated. They're already operating in fight, flight, or freeze mode, which means no matter how good the instruction is, no matter how good the curriculum is, the child is not going to be able to access that content or that learning because they're not operating in their prefrontal cortex. So one of the things that our mentors do in their daily visits is they help co-regulate so that the child closes his or her lid. So now the child can access the learning opportunities that are being presented by the teacher. So that's the social emotional learning and the executive function part of the community agency that comes in. There's also coordinated care. So there's communication among all of the services that are being provided through the teacher, the social worker, maybe the special education teacher, the family, the mentor. Everybody's in communication to make sure that if there's anything that the school needs to know about or something that happened, we find out, the child was moved into foster care, or the child is now living with grandma because mom has a substance use addiction disorder and has been taken to treatment. So without that line of communication, we wouldn't know that and wouldn't know how to best support the child. So there is coordinated care. And then all of this is embedded in the school day in this prevention, through this prevention science lens. So we're targeting executive function and skill building, which we know bolsters protective factors and mitigates risk factors. These daily check-ins help increase psychosocial and psychological safety. And then there's this notion of this coordinated communication, which is prevention. If we know that something's going on, we're going to provide some additional layers of love and support to try to prevent something from escalating within the child's life. So this is the official model. It's called the Connected Student Support System. And you'll see there in the middle, it is relationship centered. And then you'll see that it's all connected, right? So we have schools and we have communities, and everyone is pushing in within that relationship to help provide daily relational support, embedding prevention, doing specific skill building, and then coordinating care. So how does the framework work? Again, I mentioned that at the center is this relationship-centered approach, that it's grounded in trust, safety, and consistency. And there are a lot of mentoring programs out there, and I think there's a place for all of them, but it is very difficult to establish a trust-based relationship if the child only sees that mentor once a week or once a month. So that's why this model was intentional. It is every single school day, the child is going to see his or her mentor, and that helps establish this trust safe relationship. There are the outer systems, right? The schools, the families, the community, healthcare, child welfare systems, all of those outer systems that are working together in tandem, if you've noticed the arrows, to really support that relationship. The core components drive implementation across settings. So again, primarily in school, but then in the after school space as well. And it's continuous, it's integrated rather than, okay, it's, I did school and school was just school. And now after school on Monday, I'm going to go see my therapist. And on Tuesday, I have to go to the pediatrician. And on Wednesday, my mom maybe has a family session. This is all integrated so that there's systematic communication and wraparound services being provided in a very intentional way. So in terms of relationship centered, I've already kind of discussed this. The child develops felt safety and an emotional connection to the mentor. And that's this trust building. And then there's a deep sense of attunement between the mentor and the child. And it is grounded in attachment theory and trauma-informed care. So the mentors are provided extensive training in trust-based relational intervention, as well as cognitive behavioral therapy to really help target their daily check-ins to specific things that need to be strengthened or supported within the child. If you're in the education space, in the United States, we have a system called the multi-tiered system of support, and this very much aligns to that. So tier 1 in the education world is really whole class instruction. Everyone is getting core content, all of the same things, right? That's tier 1. And if you think about a triangle, tier 1 is at the base of the triangle, meaning everybody's getting that. So in this framework, every child that's part of this program gets this daily relational support and embedded prevention. And then as you move up the triangle, based on what the child or the family might need, you might also receive tier 2 services, which are targeted skill building, where we're really doing some of those focused conversations. We're doing some group sessions on executive function, how to manage your emotions, strategies for when you're feeling dysregulated, how to identify when you're about to get dysregulated, because your body gives you signals, right? Your heart starts to race and your hands might get sweaty. And we had one child tell us, I start to see red, right? So they're learning to identify what's happening in their body in a prevention way so that it can prevent them from flipping their lid, right? We're trying to keep them regulated. So some of the kids who are in tier 1 may not need that support. So they may not move into tier 2, but I will say most of the kids that we work with also need tier 2. And then fewer kids may need tier 3, which is really more specialized coordinated care, individualized intervention. Maybe an actual licensed mental health professional provides some services rather than just the mentor. So those are the 3 tiers or layers of support that are offered in this. And they align very nicely to what's happening in schools. And then again, it aligns with whole child and with national prevention models. Implementation settings. So again, most of the work that's been done using this model has been done in schools. So elementary schools, middle, high schools, but we are now branching out and also doing it out in the community and community-based programs. So more after school, summer camp kinds of programs. So it's being implemented in a wide variety of settings. So a recent research project that is actually in press right now really looked at a very large sample size. So I've been collecting data on this framework for the past 6 years. So this study has over 2,000 youth that have been, that we've collected data on, and it's both quantitative and qualitative. So we conduct pre and post measures, and then we get formative feedback, not only from the children, but also from the schools and from the families. So we've triangulated the data, and I also do implementation fidelity monitoring on site to make sure that the program is being implemented with fidelity. The measures, we looked at social emotional functioning, behavior risk indicators, and academic performance using standardized assessments that are used widely in the educational arena as well as in the behavioral health arena. For qualitative data, again, I mentioned we got parent feedback, educator impact data, youth voice. So the youth share some feedback with us as well. And then we work with school administrators and district level administrators to look at feasibility and acceptability. So I've already kind of mentioned this in terms of what the model looks like. In terms of who's providing the services, and I think this is a great way to leverage connections and community agencies that are already doing some of the work, because again, teachers cannot do any more than they're being asked to do currently. So we have Prime Fit Youth Foundation provides the mentors and the peer support specialists. So they are a community agency who are allowed into the schools during the school day to provide these daily social emotional check-ins. They come with their own funding, so they work with grants, billable services, all of those things. So family anything to have this model and these support services provided during the school day. The other partners in this model are the teachers and the school staff. We develop very close relationships with those because, again, we see them every single day, and we're there to help them as well as the children in their classrooms. We work with behavioral health providers, additional community partners. So there's this collaborative cross-sector team approach. I call it all hands on deck, right? All hands on deck to help these kids because we're trying to catch them before they're expelled. We're trying to catch them before there's a mental health crisis. We're trying to catch them before they get touched by the juvenile justice system. So what have we found so far? And if you're interested, I will be more than happy to share the actual article with the conference people to disseminate, however, but key findings is, and these data are collected pre-measure is at the beginning of the school year and post-measure is at the end of the school year. So we've seen statistically significant improvements in pro-social behavior, statistically significant increases in a child's ability to emotionally regulate themselves and identify strategies for what to do when they're starting to feel dysregulated. We also see higher student engagement, not only in academic settings, but in just their social interactions with other classmates. There were effect sizes that were moderate across the site. So this program is currently being done in 38 schools and in 5 different school districts. And regardless of the type of district, so urban or suburban or rural, we were seeing statistically significant gains in social emotional, in their ability to self-regulate. And there are consistent patterns across demographic groups. So where I'm at is a very racially and ethnically diverse school district. We have 120 languages spoken. 85% of the children that attend the school district, that's our primary partner, qualify for free or reduced lunch, which means they are economically disadvantaged. So this works with all kids, not a certain single subpopulation, if you will. In terms of behavioral outcomes, we saw a reduction in risk indicators, improved coping skills, increased resilience, and their improved distress tolerance, which is always a good thing to have as a child. We tell children all the time, we talk about conflict resolution, and I let them know that conflict is a part of life. Every day, even as an adult, you're going to experience some sort of conflict, but that doesn't mean that you need to pick up a chair and throw a chair across the room, right? You have to learn how to, 1, tolerate a little bit of conflict, and then 2, manage the emotion or the reaction to that conflict so that it's a healthy choice and a response rather than a reaction. We also noticed a significant reduction in disciplinary referrals. So again, as children learn to self-regulate, the teachers were doing less referrals to the office. And then once they were in the office, they were getting suspended less frequently because the disciplinary referral was less severe. In terms of academics, so this really spoke to the kindergarten teacher, Dr. Kim. We saw statistically improved gains in time on task, enhanced classroom participation, as well as their literacy and their math skills. And there we did some correlational analyses and found that regulation, so self-regulation, is related in a positive manner to literacy growth. So the more you are able to self-regulate, the better you do on literacy tasks. In terms of the qualitative insights, across the board, whether it was the parent, the teacher, the school staff, or the child, everyone mentioned that it was that relationship that mattered the most. Not necessarily the activity that was being done, not necessarily that, what people were wearing or if there were incentives used. It was the relationship and knowing that every day I was going to get to see my mentor really mattered to the child. Family engagement is critical. Again, just like teachers can't do it alone, no program can do it alone. It needs to be in partnership with families. And that cross-sector collaboration is essential. So a lot of the caregivers reported an improved notion of this homeschool connection because it wasn't just the teacher communicating with the parent, it was also the mentor. And so there were additional lines of communication that were happening, and the parents found that to be very positive and helped them feel more connected to the school. Teachers noted reduced burnout with support systems because they too felt supported if they were struggling with the child, because let's face it, sometimes teachers become dysregulated themselves because teaching can be hard. So if they were having challenges with a specific child and the mentor came, then the mentor can then address the child, and the teacher can take a minute to regulate him or herself as well. And the strongest finding from the qualitative research that we've done was that the youth reported feeling seen and supported. In terms of system levels, so again, we looked at each individual school, the children within each school, and then we looked at the program as a whole, and across systems, across school districts, there were reduced disciplinary incidents, improved student engagement and attendance. Our students were less likely to be chronically absent than students not in the program. There was a reduced reliance on intensive or more intervention services because they're getting preventative support. And there are a lot of cost implications to that. It is much easier to provide and cost effective to provide prevention support than it is to have to do really intensive intervention support. So embedding services in these daily school environments is more effective than using a clinical approach only in terms of positively impacting these outcomes that we've measured. The strengths of this model, it's very scalable, it's community-centered, it is prevention-focused, and it is data-informed. So what does this mean for other communities looking to do something similar? So implications for practice. Prevention science is not new. It's been around for decades. And this is really, again, speaking to this notion of we need to shift toward prevention rather than waiting for a child to fail or waiting for a major crisis to happen where then we're having to provide intervention. We need to shift toward prevention. We need to integrate services in schools. I'm a huge proponent of that because that is a very natural context for a child. We need to continue to strengthen family partnerships. And this definitely comes with challenges, but it is definitely a road we need to keep walking down because family partnerships are essential to making this all effective as well. We can work on training non-clinical staff. So not necessarily the teacher, maybe it's a mentor like Prime Fit Youth Foundation provides, or maybe it's a coach, or maybe it's a volunteer. Right, providing some training for those people in how to build positive relationships, how to work with trust-based relational intervention so that they can also be working on these relationship-centered approach and target some specific skills that a child may need. And then leveraging the mentoring as a tier 1 or tier 2 or maybe even a tier 3 support, because again, no change will happen without connection and relationship. For policy, support cross-funding or cross-sector funding. So again, PrimeFit came with funding. Lots of nonprofits apply for funding, but finding a way to fund the work so that, again, the expense doesn't all fall to the school and that no expense or minimal expense falls to the family. In my community, families are struggling enough already financially. As I mentioned, 85% of the kids that attend the primary school partner of ours are living in homes of poverty. So they cannot pay for another layer of support. That's why we capture them at school and we provide it at no cost. Investing in prevention and then if needed, early intervention. So again, it's not the intensive intervention that's needed later. And then aligning policy, aligning frameworks, aligning practices to really align with the needs of the child and focusing on the whole child instead of being a reactive system. Implications for research. So this is kind of next steps for Dr. Kim and her team. We're going to continue some studies and really look at longitudinal studies. When this program started in well, it was 2019, but then we had COVID. So 2020 was the first year we have outcome data. Some of those third, fourth, and fifth graders are now high school students, right? So following them longitudinally to see what dosage is needed. If they get it in elementary, do they also need to continue to get the same framework of support in middle and high? Or does it vary based on the number of risk factors, the number of adverse childhood experiences a child has had, like what is the just amount of, the just right amount? What is that? So looking at continued longitudinal studies, expanding evaluation models, looking at how schools identify children, what factors contribute to an outside agency doing a referral or a parent doing a self-referral to the program, and then exploring scalability across multiple states. Right now, this research has been done only in the Midwest in the United States. So what does it look like outside of that region? Expand to new communities. That's one thing that this program has worked on. We started off in one district. We're now in 5 different districts. So continuing to expand to new communities, integrating it with healthcare systems. I am working collaboratively with several healthcare providers, as well as some behavioral health providers to really integrate this support system across those larger systems. And then always looking at data, enhancing data systems, data sharing systems, so that, again, we can make informed decisions and then really look at the data to see, is this working for the child? And if not, what needs to be done differently so that we can impact that child positively? So really my takeaway message is that children don't live in systems, they live in relationships. And so our prevention efforts must meet them where they are and do all of that, what we do, within a trust-based relationship. So thank you.